Hello, my name is Rawad Mounzer and I'm currently the Therapeutic Endoscopy Fellow at the University of Colorado in Denver. On behalf of my co-authors, I'd like to thank the ASGE and GIE for giving us the opportunity to present our article entitled Endoscopic and Surgical Treatment of Malignant Colorectal Polyps, a Population-Based Comparative Study, as part of the GIE author interview series. Colorectal cancer continues to be a leading cause of cancer-related deaths in the United States. Screening and surveillance colonoscopy with polyp resection has been well established as a standard of care for the prevention of colorectal cancer. Large and giant polyps, which are polyps defined as greater than or equal to 2 centimeters and greater than or equal to 3 centimeters respectively, are associated with an increased risk of malignancy. These polyps, however, can pose significant technical challenges for endoscopic therapy. Many of these large polyps therefore continue to be referred for surgical resection. Although surgical resection is a more definitive therapy, which also allows for accurate disease staging, it is associated with higher morbidity and mortality, particularly in the elderly patients and in those patients with multiple medical comorbidities. In recent years, endoscopic mucosal resection has become an established technique for the resection of large polyps during colonoscopy. This technique predominantly involves using a submucosal injection followed by either en bloc or piecemeal snare resection. It is important to keep in mind that the depth of tissue invasion in colorectal cancer is critical to the selection of appropriate therapy. Patients with stage 0 malignant colon polyps, defined as intraepithelial cancer or invasion of the lamina propria, can safely be considered for endoscopic therapy as the risk of lymphovascular involvement and metastasis is exceedingly low. Stage 1 disease, defined by tumor invasion of the submucosa without nodal involvement, has a significantly increased risk for lymph node metastasis, with rates reported up to 12%. Surgery therefore remains to be the standard of care in these patients. Population-based data comparing surgery and endoscopic therapy is limited, and therefore the management of malignant colon polyps continues to be an area of controversy. In our study, we utilize a surveillance epidemiology and end results database to compare mid- and long-term cancer-specific mortality and survival between endoscopic therapy and surgery. We also evaluated independent predictors of cancer-specific mortality. Over 10,000 patients who had undergone surgical or endoscopic resection for stage 0 or stage 1 malignant colon polyps between 1998 and 2009 were included in this study. Patients with advanced disease, which includes invasion of the muscularis propria or beyond, patients with lymph node involvement, those who did not receive endoscopic therapy or surgery, and those who were coded as unknown with regards to tumor extension or metastasis were excluded from our study. Approximately 25% of patients had undergone endoscopic therapy and approximately 75% had undergone surgical resection. Surgical resection was found to be utilized more frequently in patients with larger polyps with a mean size of approximately 17 millimeters, in patients with right-sided colon polyps, and in those with more advanced disease. We found overall colorectal cancer-free survival to be significantly higher in patients who underwent surgical resection than those undergoing endoscopic therapy at both 2.5 and 5 years following resection. When a subgroup analysis was performed on patients with stage 0 and stage 1 disease, this finding remained significant only in those patients with stage 1 disease. Multivariable Cox proportional hazards regression models were used to evaluate the association between the modalities of treatment and colorectal cancer-specific mortality. Upon performing this analysis, we found colorectal cancer-specific mortality to be significantly lower both overall and in patients with stage 1 disease undergoing surgery compared with endoscopic therapy. There was no difference in colorectal cancer-specific mortality, however, in patients with stage 0 disease. Endoscopic therapy was a predictor of colorectal cancer-specific mortality in patients with stage 1 disease, as were disease stage and the patient's age at the time of diagnosis. Due to the potential for selection bias, propensity score analysis was performed for several confounders, including age, sex, race, polyp location and extension, patient income, and year of treatment. This analysis yielded similar results. The results of our study are in accordance with current National Comprehensive Cancer Network management guidelines for colon cancer, which state that stage 0 disease can be safely resected endoscopically, whereas surgery is recommended for stage 1 disease, with the exception of a pedunculated polyp resected en bloc with clean margins which can be observed following endoscopic therapy. There are several limitations of our study which are worth mentioning. The SEER database did not contain information regarding the medical comorbidities of patients and also did not contain EUS data for pretreatment staging. Histology of resected polyps, including the presence of lymphovascular invasion, or data regarding polyp morphology, namely Paris classification, were also not available. In conclusion, the authors recommend that patients with stage 0 malignant colon polyps undergo endoscopic therapy. Patients with stage 1 disease, however, should be referred for surgery if they are deemed to be operable candidates. In patients in whom malignant colon polyps are resected without pretreatment staging information, any evidence of submucosal invasion on pathology should prompt serious consideration for surgical resection. Thank you for your attention.